Hi, Mike Gibson coming to you live from SCAI 2017, joined by Lee Benson. Welcome, Lee. We're talking about Pediatric Interventional Cardiology. Lee just gave the Mullins Lecture. You know, kids aren't just little adults, are they? I mean, I've been learning a lot about all the differences in radiation exposure, all the differences in the regulatory pathways for drugs and devices. It's a very, very challenging area treating these kids. Tell us, in the adult world, a little bit about it.
Well, it's, for my mind, it's one of the miracles of modern medicine, the therapy for children with congenital heart disease. In the late 1940s, early 1950s, children born with cyanotic heart disease, tetralogy, particularly transposition of the great arteries, they were dead within a year of birth. Today, there are more adults with congenital heart disease than there are children, and that is because of the efforts of cardiac surgeons, pediatric cardiologists, nurse intensivists, intensive care doctors who have pushed the boundaries for care of these very little, very sick at times children.
What are some of the problems and issues that adults with congenital heart disease face now?
Well, as we're learning more about outcomes, many of the adults have normal lives. Some adults born with complex heart disease in whom we reconstruct the circulation, the surgeons do an operation, let's say a Fontan operation, where they only have one pumping chamber, so that there's just, whether it's a dominant right or a dominant left morphology, they don't have a chamber pumping to the lungs. It's not really gravity, but it goes...
Just passive flow?
Passive flow has to do with compliance of the filling chamber and the pulmonary vascular resistance, but these patients have multi-organ disease, and they're looking at heart transplantation in many cases in their 30s and 40s. Patients who have tetralogy of Fallot, who, 30 years ago the surgeons would do the repair, which included a transannular patch perhaps to relieve the right ventricular outflow tract obstruction, and they would think that these patients were cured, but now not at all. They have pulmonary insufficiency. They have to deal with dilated, poorly functioning right ventricles, for which new technologies are being developed. In fact, the first percutaneous valve was a pulmonary valve, implanted in a patient with congenital heart disease.
Wow, I didn't realize that. What are some of the biggest ongoing challenges in interventional cardiology? I mean, pediatric interventional cardiology. We're here with a lot of adults. What kinds of things are you guys dealing with?
Well, the major challenge that I see is the availability of devices and equipment that is designed specifically to address small children.
Small children who are going to get big too, right?
We treat fetuses. We do intervention on patients in utero with equipment that's not designed to do that.
Right.
We just try to figure it out, and the problem is that when you walk into the adult coronary lab, a PCI lab, everything fits. I mean, you don't have to worry if that wire is the right kind of wire, or in fact you have 20 or 30 different kinds of wires to use. In our case, we're cutting and pasting and bending and trying to make fit what's used in the adult world to be used in children. It's a challenge.
Back at the beginning, when we didn't have as many devices, we had a hairdryer in the room, and we would be shaping catheters to kind of... We still do. You have a hairdryer, okay? Yeah, well, there you go.
Yeah, we still do. Yeah. Not a hair, it's a paint remover gun.
A paint remover. That's pretty quick. That's a lot hotter.
Yeah, it is.
Yeah. Well, how do you make the transition from a fetus and fixing a fetus with some device when they're going to get to be much, much bigger someday? I mean, the vessels, the heart are all going to expand in size. How do you manage all that?
Well, the things we do in utero are more often dilations of vessels, which alter the structure of the heart in utero. And frequently these children require further interventions in the first days of life. But there are cases where We implant stents in uterus, in the child's atrial septum, in some conditions to decompress the atrial septums. And of course, those stents have to be taken out as surgical procedures later on as part of the treatment algorithm for the child.
There's a lot of cutting-edge interest in altering pig immunology or baboon immunology to allow for transplants. Anything on the horizon for kids for heart transplants from xenotropes?
Not really, although one of the first early transplants, baby Faye, which was done in Loma Linda, was baboon transplant, done by Dr. Bailey, who was a surgeon, and that child died, but she did not die of rejection. It was because of not an understanding about the ABO incompatibility between baboons and humans.
Wow, yeah.
But I think, I'm not a heart transplant doctor, but there are great strides in the kinds of transplantation immunosuppression that's being utilized. In fact, we in some cases, let's say, we want to stent the arterial duct to provide a source of pulmonary blood flow for children. In some situations, cyanotic heart disease, we're using drug-eluting stents.
Right.
And what we find when we do the pharmacokinetics, it's very interesting. You take a 4-kilogram baby, you put in a 3.5 by 18 drug-eluting stent, they're immunosuppressed for 2 weeks.
Wow.
Yeah.
That's amazing.
Because of the pharmacokinetics.
The local release of that provides systemic immunosuppression.
That's right.
That is amazing. I never would have realized that. Yeah.
But fortunately, there's no untoward effects. There's no increased infection or long-term effects. But it's, you know, you're absolutely right. Children are not small adults.
They are not. Wow. That's a lesson I just keep learning over and over again, particularly with my own kids. Yeah, great. Well, thanks so much for joining us today, Dr. Benson. Congratulations on the Mullins Lecture.
Thank you very
much. And thanks to all of you for joining us here live from SCAI 2017.